program. She holds a PhD in the history of science, technology, and medicine, and is the author of 2 books, Common Phantoms and In Whose Ruins, that deal with relationships between spiritual belief and scientific knowledge. She teaches on health politics and the political economy of health, healthcare in local and regional history, and health and science in popular literary genres. And her talk will be on, is titled, The Thing Has Not Become Known, The Desegregation of Hospitals in Baltimore. And then after she speaks, we'll have time for question and answers with our audience here. We are on Zoom as well, but the participation aspect is only for people who actually are here. And then we should wrap up by about 8:40 or so. And just the last thing I want to add is for people to please silence their cell phones. And so thanks for coming in. Here's Alicia.
Thanks so much for that introduction, Deb, and thanks everyone for being here. I was saying earlier that it's really exciting to be able to talk to people about research who want to hear about it, and to be able to talk for more than 15 minutes, because at conferences these days, they kind of like yank you off the mic after 15 minutes. So this is obviously like a very long and complex story, and I feel like even with 45 minutes or so, we're not going to get into every detail and nuance of it, but I'm really appreciative of your feedback and any additional information and insight that you can provide. So also, thanks Howie for the invitation to do this. It's a great opportunity to share our work in progress. Thanks Ada and Laura for running the tech, and also to the library for hosting, and to our amazing archivists and librarians, some of whom are here, the Chesney Archives, Enoch Pratt, Maryland Department, African American Department, and the University of Baltimore all have material that I've used for this. Who am I? You can see my affiliation. I'm trained as a historian of medicine. So civil rights history isn't my main field of study. As I'll explain, these research questions come from my teaching about social movements in healthcare and seeking greater understanding of that history in the place where I live and work. So, this is just the organization of what we're going to talk about. And the first thing is sort of considering the present day context. So these are headlines that you can see if you read the news. And they obviously have very serious implications and are part of very disturbing trends that we're living through. And so the question is, how do we make sense of what's happening? How do we understand the past and attempt to make sense of what's happening and what we can do today? So history doesn't repeat. There's an argument that hospitals never truly desegregated, that de facto segregation continued by other means. That said, desegregation was a major civil rights victory that also pushed forward demands for health rights and universal health care, and it matters how this process of social change came about. Since 1965, medical care has been rationed on the basis of wealth and geography, which continues to reproduce race and class inequality. So to remedy this would also require forms of economic rights in addition to civil rights. And attempts at using civil rights law to address ongoing health inequality have not been highly successful. So what we're looking at today is kind of this threatened rollback of civil rights that also takes place alongside cuts to public health care provision. So again, we see this role of economics in driving resegregation in healthcare such that racial disparities continue to be naturalized. And what that looks like is health systems ending specific types of services that are less lucrative, exiting underserved areas, both urban and rural, refusing public insurance, or refusing uninsured or medically indigent patients due to loss of health coverage related to Medicaid and Medicare cuts. So I'm discussing this present-day context, not to be alarmist. I understand that it is very disturbing, but to establish why we need a deeper than surface-level understanding of the history of this topic. Understanding the history doesn't save us, but I think it can help us. So we're going to start off by, in the pre-integration period, so in this period when hospitals were segregated, and understanding specifically why was that bad. We might just say that on its face, we would say it's bad, but what are the actual specifics of that? And so just as a content note, this does involve patient deaths due to denials of care. So here we are in Baltimore in 1941. A Black family called the Greens have taken their baby daughter to the hospital because she's got a high fever. They're required to wait until the emergency room is cleared of white patients to be seen. And further, the hospital claims that there are no open beds in the, quote, colored ward. And so they're basically denied care. And so this illustrates this larger problem of an artificial limit on hospital capacity created by the requirement of spatial segregation. If the Black ward is full, but there are open beds in the white ward, a Black patient will not be seen. For hospitals that strictly follow this policy. So this incident in Baltimore was not an aberration. Hospital refusal on racial grounds was very common. Private hospitals could admit or refuse patients based on criteria of their choosing. Most often race, ability to pay, and type of illness, although there are other criteria that were used. This might be shocking because since 1986, we've had a law called EMTALA that does require, so don't think, today you can walk up to an emergency room and they're required to evaluate you. But until 1985 or 6, that was not the law of the land, and hospitals could refuse for any reason. The deadliest consequences of racial hospital refusal were documented by civil rights organizations such as the Southern Conference Educational Fund and the Urban League. In 1952, the Southern Conference Educational Fund surveyed 711 southern and border state hospitals and found that only 32% of hospital beds were open to Black patients. And you'll hear a number of these surveys that were done at different times by different organizations. So the numbers vary slightly, but of course, it also depends on who's actually responding to a survey. So they sent out like 2,000 surveys, and they got 700-something responses. So just looking at some examples from this very compelling pamphlet, you can see this is a very common example. You can't control where you get into an accident. You're driving your car somewhere far away from home. You can't control whether you're near a Black hospital or not. And so these are the kinds of like extremely egregious situations and loss of life that would occur. And also they got billed anyway, just as a person dying. So segregation took many forms in hospitals. Some municipalities had a white-only hospital, and a separate Black hospital was built either with public money or by the Black community through donations. Some hospitals served both races but had segregated wards with a fixed number of Black patients admitted. And since we don't see this often today, I'll be using the term ward, and that's a large open area with lots of patients in it. These are generally spaces for non-paying or charity patients. So you can see that race and class, again, are inscribed together in these histories of the spatial arrangements of hospitals. So public or charity patients on the open ward, paying patients typically have private or semi-private rooms. However, Black patients who could pay for their care, who were private patients or paying patients, were sometimes still housed on wards, which was an indignity for those who felt pride in having hospital insurance. So you have your job, you have Blue Cross, and yet you still can't get that semi-private room, even though you have the same insurance policy as your white coworkers. Akron City Hospital, which had semi-private rooms for everyone rather than open wards, refused to admit this patient in 1951 because the only available bed was in a semi-private room with a white patient in the other bed. The 18-year-old patient died in the emergency room after waiting 31 hours for hospital admission. So the situation was very bad, and the way that in the late 19th and early 20th century Black communities responded to this was essentially through self-defense, self-help. Historian Vanessa Northington Gamble terms the response of Black communities to Jim Crow segregation the Black hospital movement. The establishment of community-controlled Black hospitals had two purposes: the care of Black patients and the training of Black medical professionals who were barred from internships, residencies, or staff positions in white hospitals. Throughout this presentation, I'll discuss both patient care and professional training as twin goals of medical civil rights activists, many of whom were doctors. Providence Hospital was established by Black physicians to serve Baltimore's Black community in 1894. However, as in other cities, it was never possible for one underfunded Black hospital to serve the entire large and geographically dispersed Black population. So again, it's that question of like, if you happen to fall sick or get into an accident on one side of town, you should be able to go to the nearest hospital. So returning to our example of the Green family, their child was okay, fortunately. They left Mercy, and they actually went to Hopkins. And their daughter was treated and survived. Johns Hopkins Hospital was segregated, but had a larger overall capacity. I have not personally found reports of patient refusal at Hopkins, but I'm interested in any information about such incidents. Sources such as the Afro and Urban League suggest that Black residents saw Hopkins as one of the institutions from which they would not be turned away, along with city hospitals, Providence Lutheran, Sinai, University of Maryland, and Franklin Square at different times. Upholding segregation went against the Hippocratic Oath, as you can clearly see in these cases of patients who were previously injured or died. And it also went against the perceived public responsibility of hospitals as nonprofit charitable institutions. However, it violated no laws, as private hospitals had the right to accept or reject patients based on their own criteria. Some practitioners and administrators believed in segregation. Many believed that segregation was necessary to retain white patients, and others were just following the policy, in scare quotes. Many hospital employees personally objected to segregation, but continued in the course of their duties to maintain a segregated environment. Now is an important time to consider how people respond to unjust policies, including in the hierarchical and rules-based healthcare sector. When we ask, what would I do in that situation, we are often thinking about whether we would make the right choice in an individual moral dilemma. But I think this is a question about strategies, movements, alliances, and long-term commitments. Understanding this history is not about choosing heroes and villains, but about understanding how a process of large-scale social change takes place and what role differently situated actors play. So, you've heard of civil rights protests in Baltimore to desegregate lunch counters, swimming pools, parks, and stores. How many of you have heard of a civil rights picket at a Baltimore hospital? And this is a sharing. Have you heard of such a thing occurring? So why do you think that's not something that you've seen in histories of civil rights here? The presence of providence? I think that the healthcare sector saw Providence as kind of a safety valve in a way, because they could always say, oh, we'll just go to Providence. So that's one possibility. Anything else? this is very much like, this is part of the research question. Why were these not sites of public contention? And so what we hear from historians of medicine is this sense that hospital segregation received little public attention, and most of the changes took place quietly behind the scenes. And this is historian David Barton-Smith. So while the federal government would ultimately force the hand of recalcitrant segregated hospitals in 1965 by leveraging the new Medicare public insurance program, the desegregation of hospital beds and staffs was already underway in many places, including in Baltimore, by the early 1960s. So David Barton-Smith poses the question of how and why these voluntary steps were initiated. Again, this idea that this took place quietly behind the scenes. Historians suggest that doctors and administrators, quote, had no real stake in maintaining segregation, and once social attitudes began shifting, they, quote, moved forward voluntarily. In kind of a natural progression that was devoid of politics. It was just the right thing to do. The process is little remarked upon even by those who experienced it. One Black physician in Georgia remarked that his white colleagues, quote, acted like it was never any different, like segregation had never existed. So when we're hearing this, we want to know, clearly there's something important that's going on quietly behind the scenes. What is that? How can we recover that memory? So the rest of this presentation will explore how segregation was ended at institutions that integrated voluntarily, and what we can read into the sense, this sort of pervasive sense of quiet that surrounds this change. And we're going to do a case study of Johns Hopkins because that's the institution that I'm most proximate to. This research came out of my teaching at Hopkins. I realized that I didn't know how this happened, and so I started by looking where I was. And this is actually, and Hopkins is unique in some ways. I don't want to say that it's exceptional because all institutions were dealing with this same set of forces. There are some distinctive things about its history, specifically that it was initially chartered to be an institution that did not discriminate by race, whereas most other hospitals in the city were very clear about that from the beginning. So this is from even before the hospital was built. This is 1870 when Johns Hopkins was purchasing the land for the hospital, and property owners, these are white property owners in East Baltimore, objected to the purchase of that land and the planned construction of a hospital because, quote, a hospital in this city conducted without respect to race or color can be nothing more or less than a Negro hospital, close quote. So their main concern here is with the diminishment of their property value because a hospital that served Black and poor patients would blight the area, in their view. So this was like a bone of public contention. There were these hearings with the community, as in the property owners in the area. And ultimately, well, in 1870, the Board of Trustees publicly committed that, yes, we will segregate this hospital, but then the hospital was constructed and it did not have these segregated facilities. So it opened in 1889, and there was no spatial system for segregating patients. In 1890, the administrators come to the Board of Trustees and they say, we need a segregated ward, and then they find the money and they build it. And so that's kind of this distinctive pathway to this status quo Hopkins. So here we are some decades later in 1949. At this point, Hopkins occupies a liberal position relative to other white-run Baltimore hospitals, some of which refused to serve Black patients entirely. Black physicians were largely denied admitting privileges and staff positions. Hopkins brought the first Black doctor, Dr. Ralph Young, onto its staff in 1946. Providence Hospital, established by Black physicians in 1894, served the Black community but could not come close to meeting the full demand. As the city's Black population grew from 15% of all residents in 1910 to 25% in 1950, the artificial limitation on beds available to Black patients became a source of increasing concern. Johns Hopkins Hospital maintained that it provided separate but equal care. Rufus Wells, a writer for the Baltimore Afro-American newspaper and a civil rights activist, communicated this message to Black readers in 1949. The races are separated in Hopkins wards, he wrote, but the hospital administration makes a special point to see that all get the same type of treatment and care. Wells offered an encouraging assessment. Despite grievances over the lack of private rooms for Black paying patients, Johns Hopkins is Baltimore's most liberal hospital and was, quote, making progress towards treating all alike. And so you can read a lot into this language. I think coverage like this is really rich in the sense that it is performing something. It's trying to position this sort of leadership of the Black community in a particular relation to these white institutions, where they are encouraging good behavior through praising certain things and making these very gentle kind of criticisms. So beyond such ameliorative statements, Wells hinted that the Black community had a claim on the institution. Quote, few persons realize the important role colored persons play in the operation of this world-renowned hospital, he noted, pointing out that 40% of Hopkins employees were Black, though he chose not to emphasize the low pay for largely Black non-professional workers that would later lead to their unionization. At that time, Hopkins operated on $1 million deficit. Wells reiterated administrators' fundraising plea that its real work is treating those who cannot afford to pay for the full cost of treatment. And these quotes are emphasized in multiple Afro stories from the 1930s through the 60s. They underscore the founding vision of Johns Hopkins to serve all, regardless of race, color, or creed. They mention some wards which are integrated, point to inferior conditions on Black wards, demand access to private rooms for paying patients, and insist that segregation must end. And they also often highlight the work of Black healthcare workers and other staff as part of what made them feel cared for as patients. So sometimes in a newspaper you'll have a columnist who's like, I was in the hospital for this or that, and this was my experience, and they'll comment on these things. So, getting to our question, so how did this spatial segregation end? And we're going to explore a few different options. I think all of these are important. None is the sole explanation. We're asking how these operate as part of an emergent process of social change, and also the role that they play in public memory. So here's one perspective on the end of segregation. At Hopkins Hospital, Richard C. Reynolds was the assistant resident in charge of the emergency room one night in 1958. That night, the Black inpatient wards were full and the sick and injured were backed up in the holding unit, not receiving proper care. Reynolds wrote publicly about this experience for the first time more than half a century later. No matter how hard I tried, I could not meet even the minimal needs of the mostly Black patients in the holding unit, he wrote. What was the matter with me? I could not get it done. So that's interesting, right? He's saying that this is his responsibility to just move faster. So in what seemed an exceptional moment of crisis, these two institutional policies, segregation and clinical excellence, came into conflict for him. And no matter how hard he personally worked, he could not reconcile them. The only way to ensure proper care and forestall a catastrophe was to put Black patients on white wards, he recalled. Reynolds makes clear that the sacrifice of human lives for the enforcement of racial segregation would not be morally acceptable. I could not stand to see the situation deteriorate before me, he wrote. So this is kind of a narrative about clinical ethics, medical ethics. It's focused on the responsibility of individual practitioners. Reynolds' next move is that he made a midnight call to his chief resident, who called the chair of the Department of Medicine. Issues of racial or social justice were not discussed, Reynolds states, nor was explicit reference made to the hospital's segregation policy. Adhering to the norms of professionalism, the conversation was all about how to get the best care for patients with critical conditions, he said. So Black patients were placed in beds designated for white patients, and, quote, Hopkins never returned to segregated floors even when beds freed up, close quote. In this compelling first-person narrative, a medical trainee brings about a small but significant institutional change by placing medical ethics above social prejudices. So that's our first narrative. Now we're hearing from the administrators. According to the administrators, there was a goal of gradual desegregation that they were pursuing throughout the late 1950s and early 1960s. So while Reynolds, the medical resident, experienced that night in 1958 as an exceptional moral crisis, Luis Cavagnaro, a senior administrator who helped to implement desegregation at Hopkins, asserted that for some unspecified time before desegregation began, quote, when the units were crowded, the practice of admitting a colored patient to an empty bed in a white ward was not uncommon, close quote. Seemingly, knowledge of this exception was not widespread, as Reynolds felt he was taking a huge risk by violating the segregation policy. In a workplace characterized by frequent turnover of personnel and where the policy was not discussed, each trainee doctor might face this dilemma anew. And so a lot of practitioners who were working in that period have memories of individually transgressing segregation policies. And there are a lot of these recollections of white medical students who came from the north to the south, and their feelings of shock upon encountering racial segregation in medical facilities, often failing to recognize similar discrimination that did occur in the north. Many of them described a sense of helplessness and complicity, and their low status in the medical hierarchy made them afraid to speak out. However, of course, by the 1960s, medical students became, in many cases, active participants in the civil rights struggle. For their part, liberal hospital administrators saw segregation as backwards and integration as inevitable someday. Yet, the spectacle of massive resistance to Brown v. Board reinforced their hesitations about attracting public attention. They were not radicals, and they feared social upheaval reaching into the sanctum of the clinic. So Cavagnaro was part of the liberal-minded administrative team that oversaw the desegregation of Hopkins wards. She produced a 1992 report on this history based on her own experience and the recollections of other administrators and doctors, because most policy changes were not documented. She recalled that leaders made no public announcements in order to avoid backlash. In 1955, she began admitting Black paying patients to certain private rooms in the same building as white paying patients. According to Cavagnaro, in 1959, the surgical wards were integrated and the medical wards followed. I have not found, she says there's not documentation, I have not found documentation. So these dates are, I can't pin them down. In a story about the tenure of hospital president Russell Nelson, the Baltimore Sun gives 1964 as the year that the hospital became truly integrated, without explaining what they mean by that. So I think 1964 is a year where the public, like the newspaper writer, can name Hopkins being desegregated, is an interesting data point for us. So without a public uniform policy change, there was no chance for people to protest desegregation, which was the goal of this whole approach. But there's also little record of what happened. In any case, we have to look outside institutions to understand why desegregation happened as it did. So we just looked at Hopkins, but there are a bunch of other hospitals in the city that were engaging with this issue also in different ways. Some of them were taking this same gradual approach, and others were resisting. So no institution is acting in a vacuum. There was a network of forces driving change at the local, state, and national levels. So we're hearing that this is a quiet process, but where is the noise amid that silence? For institutions, the urgency of clinical care was primary for them, and they did not want to attract attention that created an opening for racist resentment. Even Black physicians accepted this approach as strategic for them. They too were committed to the professionalizing ideals of early 20th century medicine. And of course, they were held to a higher standard of professionalism than their white counterparts. As a result, the role of social movement activism is de-emphasized in many accounts of voluntary hospital desegregation. But there should be no question that Black organizing and coalitional work lay behind these events. So this was a decades-long struggle for desegregation that was waged within medical and hospital associations, civil society groups, and in the media. So now we'll talk about it. And this is an image from a column that was run regularly in the Journal of the National Medical Association, which was the Black national level physicians association. So in this section, in this overview, I'm drawing heavily on Betty Robinson's work, her research documents and unpublished paper in the University of Baltimore archives. And so she took a class at Hopkins, and she did all of this research and all of these interviews about this question. And so when I started wondering about this myself, that was one of the first things that came up in my searches, and I was like, Betty has already been here. She has just done this incredible research, and put together the pieces of this story that would have been very difficult for me to locate. And so this is entirely Betty's, this is building upon a lot of really incredible work that Betty did. And I am presenting it to you with some additional synthesis that I can provide as a historian of medicine. So, this starts with a pivot in 1945. There is a push to desegregate white-controlled hospitals at the national level. Vanessa Northington Gamble writes that the Black hospital movement of the early 20th century gave way after World War II to a demand for full inclusion and equality. It became clear that Black hospitals would not be able to raise as much money as white institutions, creating what leaders called, quote, a Negro medical ghetto, close quote. Further, during World War II, Black military doctors had cared for white patients and served as equals with white peers, only to return home to segregated practice. In 1945, the NAACP and the National Medical Association, again, that's the professional association for Black physicians, joined forces to pursue hospital integration. The National Medical Association believed that hospitals and the medical profession could be integrated without legal intervention. The medical profession had been largely self-regulated in the US, and the NMA's strategy was to seek voluntary change by working with the white-controlled American Medical Association and the American Hospital Association and local chapters. At the same time, the NAACP also supported lawsuits against segregated facilities, contesting federal statutes such as the Separate but Equal Clause of the 1946 Hill-Burton Act, and raising the possibility of a compulsory end to segregation. The Truman administration's 1947 Commission on Hospital Care recommended the abolition of segregation, yet without any formal mandate or means of enforcement. So this also involved a major push in media. These stories exposing, what we've just covered, the harms of segregated medicine, the harms of health inequality. And this is taking place in the Black press, but also in mainstream publications like the Saturday Evening Post. Importantly, while hospital integration was the leading demand of this campaign, it was also framed as a first step toward achieving health rights, a reasonable standard of health and medical care for all. Recognizing that economic barriers to care would remain, the NMA also supported public programs, so later on, restoring Medicare, and subsequent proposals for universal health insurance. Their strategy is very carefully thought out. The NMA's efforts to persuade the medical profession against segregation were coordinated by Dr. William Montague Cobb of the Howard University Medical School, who became president of the Medico-Chirurgical Society of Washington, D.C., which was that city's Black medical society in 1945. In his first presidential address, Cobb assessed the segregated medical landscape and identified a pressure point, the public hospitals. So public hospitals, taxpayer funded, all of our tax money goes to run them. They should not be turning people away. So that's their first move. In meeting with civic leaders, he affirmed our particular interest in the integration of Negro professional personnel at all levels in the health facilities of the District of Columbia, particularly of physicians in the municipal hospitals. The following year, Cobb and the NMA won integration of the staff of the city's Gallinger Municipal Hospital. At the same time, the NAACP launched a campaign for integration of Veterans Administration hospitals nationwide on a similar principle, right? These are taxpayer-funded institutions. These are serving veterans who, serve their country, and there should not be inequality and discrimination. So, in the mid-1940s, the Baltimore-Washington region had a local Black-led campaign for hospital desegregation in concert with the national agenda of the NAACP and NMA. The leadership of Baltimore's healthcare and social service organizations took notice. For the first time, they produced surveys and studies assessing the state of racial segregation and unequal health services in local hospitals. A previously naturalized practice became a matter of concern. The effort of the Urban League was to demonstrate the harmful impact of segregation, while the effort of white administrators and planners was to preserve hospitals' autonomy by suggesting that the practice was not highly prevalent, strict, or impactful, and thus could be addressed through voluntary gradual change. The Baltimore Urban League had long collected data on health issues, such as the spread of tuberculosis in overcrowded neighborhoods. In 1950, the Urban League published a community audit of the city's race relations, including health services. Under credits, it noted that the white-controlled city and state medical societies had technically opened their membership to Black practitioners in 1948, although none were admitted until 1950. Under debits, the authors presented a stark accounting. Of 23 hospitals in Baltimore City, 13 admitted Black patients, and 11 of these in segregated wards or beds. Thus, only 12% of the city's hospital beds were available to African Americans, who made up 20% of the total population and suffered from proportionately higher incidence of illness due to structural social conditions. Further, no white-controlled institution had ever admitted a Black intern or resident. And I think the two hospitals that didn't segregate were Providence and Sinai. So, in the face of this sort of evidence, white-controlled professional and hospital industry bodies, such as the Baltimore Hospital Survey Committee, continued to emphasize gradualism and minimize the concerns of Black physicians about their lack of admitting privileges at local hospitals. And just for reference, admitting privileges is the ability to have your patient admitted as an inpatient and to then also provide care for that patient. So Black doctors would have to just give the patient up at the door. At the beginning of 1956, former Johns Hopkins School of Medicine Dean Alan Chesney penned an op-ed in The Sun that predicted a slow pace for hospital integration in Baltimore. Later that summer, the publicly funded Baltimore City Hospitals desegregated its wards, reportedly due to the demands on the facility from a polio outbreak. However, as we just discussed, the common story of sudden desegregation due to an emergency is often more complex than it appears. So the historian here, Harry Dowling, gets his information from personal correspondence with the city hospital's physician. We know that public hospitals were a target of medical civil rights activists in Washington, D.C. and elsewhere, and that their strategy was directly shared through the NMA network. So I wish that the records of City Hospital had not been destroyed, because there might be more information about that. The Imhotep conferences were organized by the NAACP and the National Medical Association beginning in 1957 to promote hospital integration and equality of professional standing. They were attended by Baltimore physicians such as Drs. Marcus W. Morris Sr., John Chissell, and Emerson Walden. The figure of the ancient Egyptian priestly physician Imhotep, he who cometh in peace, symbolized the NMA's strategy of amicable but firm and unceasing pressure on healthcare industry associations. And I thought it was interesting that there are reports of this conference mention that there is apprehension in the present atmosphere of racial tensions, and that this made it difficult for them to secure a venue, and that many organizations refused to send representatives. So when we're in a sort of time when public discourse is chilled, it's always helpful to look at these times in the past, when it's like, oh yeah, people were actually afraid to show up at this. Nevertheless, their goal was to achieve desegregation by, quote, a meeting of the minds in the medical profession, rather than through litigation. A, quote, peaceful revolution, in the words of Baltimore Dr. Emerson Walden. Some amount of respect for their Black counterparts did seem to move the white medical establishment. By 1958, the Hospital Council of Baltimore reported that, quote, there are a number of white persons in the hospital field who believe the distinction of race should be ignored. Praising white institutions that integrated and shaming their segregated peers was a frequent persuasive tactic. In 1959, the president of the Urban League praised Sinai for, quote, setting a pattern of non-racial policy as to admissions and professional employment that the majority of other hospitals would do well to emulate. In 1962, the Maryland State chapter of the NMA pressed the Maryland Hospital Association to form a joint committee on integration, which Robinson describes as their culminating campaign. The Joint Committee met from 1962 to 1964, conducting a survey on racial discrimination in Maryland hospitals. And we've already seen different versions of this survey before, so part of their process is like, we're going to do the survey again. You don't believe the Urban League? We're going to do another survey. We're going to talk to each one of you face to face. So these committee members felt that the survey itself and their follow-up interviews with 35 hospitals had materially pushed forward integration. Johns Hopkins Hospital President Russell Nelson served on the Joint Committee. Its report is in the Hopkins Medical Archives. While desegregation had already taken place in some Hopkins wards, by 1963 the hospital had formed an internal committee to review the procedures of the admitting office, as recommended by this statewide Joint Committee. After that point, knowledge of Hopkins integration seemed to become more generally available to staff and to the public. The University of Maryland Hospital desegregated its male ward service in 1962, also likely as a result of the Joint Committee's activities. The city's Catholic hospitals, long seen as holdouts, announced an open-door racial policy at the direction of the Archbishop 2 weeks after meeting with the Joint Committee. We can trace the voluntary desegregation of Baltimore's hospitals in the late 1950s and early 60s not solely to ethical self-reflection, the expectation of a federal mandate, or the perception that society was naturally progressing towards integration. All of these factors were themselves conditional on sustained and coordinated pressure from Black organizations, medical professionals, and their allies. The Journal of the National Medical Association described Baltimore in 1964 as quote, moving quietly towards desegregation. That ubiquitous word, quiet, is a fruitful metaphor to consider as it pertains to the different actors in this process and to the political identity of medicine as a whole. All was not really quiet. While Black organizations and their allies saw the pragmatic elements of a stealth approach, they also contested them in various ways. And I would add they used them when it was a strategic advantage to use them. So, in this exploration of quiet, what is quiet, I'm also referencing this idea of the hospital as a quiet zone. Labor historians Leon Fink and Brian Greenberg characterize the hospital as the quiet zone in their history of the Healthcare Workers Union, Local 1199. In the first half of the 20th century, the hospital was treated as a quiet zone where the social, economic, and political structures shaping care would not be explicitly discussed or contested. The Black physicians leading the charge on hospital desegregation faced a conflict. They identified with and sought to maintain the dignified quiet of their profession, yet they saw that overcoming segregation required urgent collective action. The generation that followed them, including those who attended medical school in the 50s and 60s, would be very outspoken as to the political nature of health inequality. While we might see this as a paradigm shift marking the beginning of 60s radicalism, I would like to highlight continuities by looking at the seeds of these later developments in the quiet zone. Quiet, as much as loudness, can be a prerogative of power. It was used in this way by segregated institutions, which maintained that the emotional agitation of racial mixing would harm patients. Maintaining quiet meant maintaining the decorum of the medical profession, and thus quiet was a requirement for Black doctors to win acceptance into the white medical fraternity that controlled access to hospitals, training, and funds. Black doctors also used the medical profession's fear of noise to position themselves as mediators in an internal process that could erupt into the antagonistic public realm of lawsuits, hearings, and protests. These activists won concessions through private committee meetings because everyone could see the Montgomery bus boycott and the March on Washington, as well as the violent responses to protest by white police and mobs. At the state and city level, civil rights bills were moving forward in 1963 that promised to bring comfortable scrutiny to local institutions. Dr. Cobb directly referenced the specter of disruption at hospitals in his 1964 appearance at a joint committee meeting. If hospitals could not find answers to the problem of discrimination, there are always organizations that can throw a picket line around them. So Cobb is coming into town as a national figure, and he can sort of wield the stick in these local negotiations, whereas the local negotiating partners are, sort of being the good cop, as it were. Black medical leaders were not silent regarding the uses of quiet by their white counterparts. They recognized it as a stalling tactic. To white administrators' claims that integration would agitate psychiatric patients, which conjured the threat of violence within the hospital walls, Montague Cobb reported that many Southern psychiatric services had been integrated for years. Cobb observed that the attribution of violent racism to psychiatric patients was likely a projection of the administrator's own fears and biases. Cobb was backed in this assertion by Jerome Frank, the director of Hopkins' Integrated Outpatient Psychiatry Service. Frank was outspoken on racial equality throughout his career. Dr. Ethel Nixon was appointed to the Hopkins Department of Psychiatry in 1950, the first Black woman physician to practice at the hospital, I think, although sometimes one always finds new firsts. Pediatrics. Outpatient departments were often the first to hire Black practitioners. Quiet also marked the integration of medical schools. The Journal of the National Medical Association listed the Johns Hopkins School of Medicine as still closed to Negro students in a 1961 report. Soon after, New York Senator Jacob Javits sent an inquiry to the school regarding their policy, and it was informed that its doors are open to Black students. Learning of this change, Dr. Cobb trenchantly pointed out that, to use a biblical paraphrase, the thing has not become known. Cobb praised the new policy and acknowledged the internal resistance that it faced, but he returned to the reality that integration had to come out into public view to be meaningful. It was too shining a light to have been kept under a bushel, he quipped. The journal agrees with the Hopkins authorities that real progress has been made, he declared, and will help spread the information that Hopkins is now open and that top-flight students will have no difficulty in gaining admission. Cobb's ironic undertone was borne out by the fact that only 2 or 3 Black students were admitted annually among classes of 350 to 400 until the events of 1968. So, in a separate stream of our healthcare history from the medical civil rights struggle, elderly people in the U.S. were being quite noisy and confrontational in their demands for public health insurance. So it's quite a contrast, this sort of very quiet and delicate process, but then there are these crowds of elderly people climbing the stairs of their congressman's office and gathering in the streets with this demand because they were not insurable through private insurance. Here they're picketing the AMA. So we're picketing the AMA because the AMA is opposed to Medicare, as well as any other form of government insurance. So the National Medical Association endorsed and campaigned for Medicare and Medicaid, as well as expanded national health care proposals, recognizing that even with civil rights, many Black citizens faced economic exclusion. Nothing required hospitals to care for people who couldn't pay. Dr. Cobb observed in 1962, the senators who opposed medical care for the elderly through Social Security were almost to a man those who traditionally opposed civil rights legislation. So there's this mass movement of the elderly, and the NMA is bringing it together with their goals. For hospitals that clung to segregation, largely in the Deep South, neither Brown v. Board nor the 1964 Civil Rights Act was sufficient to compel change. Only with the passage of Medicare and Medicaid in 1965 did the federal government gain the leverage it needed. Hospitals could not receive Medicare funds without civil rights compliance. So, highly recommend David Barton Smith's book, The Power to Heal, and the PBS documentary by the same name. These works tell the powerful story of the activists and civil service workers who risked their lives to root out hospital segregation on the ground. And this was very dangerous work. People lost their lives in this process of inspecting hospitals. The Medical Committee for Civil Rights, later the Medical Committee for Human Rights, was the healthcare workers group engaged in this process. A Baltimore chapter of the MCHR formed in 1965 and investigated hospitals in rural Maryland, but I have not located evidence of a Title VI investigation into hospital segregation in Baltimore City, although there were other civil rights investigations of hospitals, just not specifically regarding segregated wards. So this work was not finished. Even as the signs for Black and white wards, bathrooms, and water fountains were removed, segregation was shifting its form. Hospitals followed white flight away from deindustrializing urban centers to the suburbs. Class and geography were proxies for race. Type of insurance, private or public, also acted as proxies to ration care. Systemic biases led to worse care for Black patients regardless of their income, zip code, or insurance. Formal segregation was only one mode of racial inequality, and ending racial inequality is, of course, an ongoing struggle. What ultimately broke the silence in the quiet zone was precisely the continued persistence of inequality, both outside outside and within hospital walls. Following the assassination of Martin Luther King Jr. and the urban uprisings of summer 1968, the growing militancy of social movements reached into healthcare. Underpaid non-professional workers unionized almost overnight at Hopkins, Franklin Square, Lutheran, Maryland General, and in area nursing homes, shifting the center of gravity in healthcare struggles from middle-class practitioners to working-class staff and patients. Montague Cobb's threat of a picket line at the hospital materialized, and the world did not end. Patient care continued. In the wake of deindustrialization, healthcare became an economic pillar that could not stand without state funding and political mobilization. Labor perspectives on healthcare echo an argument for desegregation that the welfare of healthcare providers and that of patients is not separate but intertwined. At this point, people have been making noise about health inequality and health rights for a long time. We are no longer shocked by a die-in on the steps of a medical school or a picket line outside a hospital. Yet, in today's high-volume algorithmic biopolitics, the most powerful voices are those who dismiss the lives of the sick, disabled, and poor as worthless. The internet terms this saying the quiet part out loud. I don't think this is a failure of activists to make the case for their own right to exist, but a failure of institutions and policy. Historian James Chappell writes of the exhausted pragmatism that characterized late 20th century liberal discourse about social welfare, a refusal to imagine anything beyond complex technical reforms and strict budget discipline. As we are seeing, the exhausted pragmatists were wrong in that things can change very fast. But what appear to be rapid changes are built on deep networks of power and on political vision. Things can change in any direction. The Medicare program was implemented in a year, and hospital integration swept the South on its heels, but this would not have been possible without the work that occurred in places like Baltimore, where advocates labored on the dangerous edge of quiet. This layered history is an invitation to think about strategies, movements, alliances, and long-term commitments in times when both the silence and the noise feel deafening. Thank you.
Alicia, there's a lot in that talk and a lot of raises a lot of interesting points and such a complex subject. So we do have time for about 10 minutes or so of questions. Does somebody want to start off? If somebody asks a question, I will repeat the question so that it will be recorded on Zoom. So, yes.
Did your research include anything about nursing?
So the question is, did the research include anything on nursing? And you'll have to use that.
That's a great question, and there is a lot about nursing and nurses, and I kind of have committed the maybe lazy act of focusing on the history of doctors, but there is a ton about nursing and nurses.
Well, the doctors were mostly men, is that right?
Yes.
Close to 100%?
Yes.
Okay, so where were the women in this school? Nursing school was desegregated before the medical school did, and also had black nurses on staff before the hospital, before the doctors, black doctors were admitted as interns.
Yes.
Public health was actually before.
Okay, so I'm repeating what Phoebe said, which is that nursing schools integrated before medical schools and were typically more inclusive of black nursing students. The public health school also preceded the medical school.
And the nursing school.
And the nursing school. And I think a lot, thinking about the Medical Committee for Human Rights, a lot of members of that organization were nurses, and that group started out during the Freedom Rides. they were there to provide direct medical aid to people who were being brutalized. So nurses were a very strong presence there.
Mike, did you have a question?
Maybe tangential to your main issue, but related to this, what we were just talking about. I was surprised when you showed that major administrator at Hopkins Hospital who was a woman. Was that unusual in those days?
Yes.
So the question is, was it unusual for Hopkins to have a medical administrator who was a woman, which was shown, which seems like it would have been.
She was the first female administrator at Johns Hopkins Hospital. She came from Portland, Oregon.
Okay, so she was the first female administrator at Hopkins.
Not from the South, she was coming from Oregon. Very
Coming
proud. I
from
knew her
Oregon.
staff.
Is she a doctor or a
She was an administrator. She was an Army nurse in World War II, had been in Japan, and was the nurse in charge of the Atomic Bomb Casualty Commission, and took that experience, and then went to Columbia University for a hospital administration degree, and worked at Hopkins as the administrator in Department of Surgery.
So there was a question back here?
Yes, so, thank you for this presentation, it was great. So you were talking about a lot of data about, like, desegregation related to percent of hospital beds available, right? And so I was curious, is there any information or data out there about, like, how that translates further to, like, patient outcomes or, like, mortality rates and things like that, and maybe, like, how it changed, like I think you mentioned that, like, 1964 date. So I was curious if you found any information along those lines as well.
So the question is, with fewer hospital beds available to Black people, was that measurable in outcomes?
Yeah, like were you able
Were there studies that show what the outcome was for people's health?
So I think that it was a struggle for them to even get the data regarding the number of beds available at different institutions, and I'm not sure if I haven't read something that correlates that disproportionate sort of denial of access with health outcomes further along the line. But it's very possible that someone did that work, and it's just something I haven't come across. But consistently what they are arguing is that this is already an overburdened population. Therefore, we can expect that the Black population is going to need medical care that is not precisely proportionate to their percentage of the city demographically. And so I think that there's this broader understanding that, like, public health is intersecting with hospital care and with structural inequality in this way.
Certainly the anecdotal evidence, you came up with a few stories about what happened when people were denied medical care, but I could see where it would be hard to come up with statistics about something. Josh, did you have a question?
Yeah, it's a really great talk. Provocative, just raised a lot of nice questions. I was wondering, a lot of oral histories about the desegregation of Southern schools, oral histories from the 80s, 90s, 2000s, from Black Southerners simultaneously acknowledged desegregation was totally necessary, and yet Black schools paid a terrible cost because the desegregation of schools was always a burden for Black schools. Black principals were fired, Black teachers were fired, Black communities lost mascots. And so I'm curious if you've come across any sentiments like that in oral histories that were done afterwards, or even maybe gesturing towards that in the 50s and 60s, when maybe Black doctors realized it's going to make their lives harder in some ways because white hospitals will generally discriminate against them. And even if they desegregate, Black hospital closes, potential job loss for Black medical professionals. So I'm just curious if any of that has ever come up subtly or even explicitly in any research.
So the question is about the impact of desegregation on Black hospitals and how it might have affected their ability to sustain themselves.
So similarly to what you're saying about the desegregation of public schools having these very complex ramifications that in some cases disadvantage Black teachers and Black students, the story with Black hospitals is, that there was I don't think that any participants in the medical civil rights movement regretted the demand for inclusion and the achievement of technical inclusion, like not explicitly being excluded by race. But certainly when you look at the history of Providence Hospital in Baltimore, there's this long-running conversation about should we still keep going to Providence even though the other hospitals are desegregated, because Providence doesn't have the same amount of capital as these white hospitals. So it's just like this so there are historians, Vanessa Norton Gamble is the person that I would go to on that. But yeah, there is like sadness about the loss of Black hospitals, which in many cases were not able to financially sustain themselves. And especially what they already knew, which is that they were providing care often for non-paying patients, more so than these white hospitals that attracted an elite clientele, and so that could kind of counterbalance. So yeah, the trajectory is definitely one of like continually losing resources, yet still being a point of pride and identity, because it was created by the Black community. So the history gets painful, I think, there at the end of Providence. But yeah, thanks for the question.
I think maybe we have time for one more. Is there any other questions? Oh, yeah.
I was just curious about your thoughts on the motivation for why Johns Hopkins Hospital, from its inception, was choosing not to segregate even as early as like 1880. So that's, I was just curious.
Yeah, the question is, what was Johns Hopkins' motivation for wanting to be desegregated from the beginning?
So I think that my received understanding of that is that Johns Hopkins, the man, was a Quaker, and he opposed slavery, and he chartered this institution as one which would not, in the sort of Quaker tradition, would not discriminate based on religion, race, or anything else. And so the process of realizing, this is all in his will, then he dies, and the process of realizing the instructions in the will is in the hands of the trustees, and they're making decisions, and they're talking about, well, this is Baltimore, and people simply won't have it. And who are these people? So that's sort of my surface level understanding of it. I will also defer to Phoebe, who has been around the block with the question of the early days of Johns Hopkins.
Yeah, I'll have a conversation offline.
Okay. Actually, I'm just going to sneak one question in here. You did mention that Sinai was desegregated before Hopkins, really. Can you say anything about that?
Sinai was right across the street from Hopkins at the time, in the 19th century. And so I actually haven't been able to pin down the date, if there is one, when they officially changed their policies, but I haven't spent as much time looking for it, and I think I might once have known it's somewhere in my files. But Sinai is a Jewish hospital. There's some amount of understanding of what it's like to be excluded. And there's a Jewish angle throughout this history in the sense that Jewish doctors, again, coming to Hopkins from the north, were both shocked by the explicit racial segregation and also themselves in a vulnerable position because Hopkins was not very friendly to Jews at the time. And so their observations of the experience of training and practicing medicine under segregation are very interesting because there's this sense of some resonance of the vulnerability and exclusion. While at the same time, it's obviously they're in a different position. So that's not directly related to Sunday, but I think there's a lot of specific Jewish traditions will crop up in this story and be very outspoken about this issue.
Okay, well, thank you all very much. We still have a few snacks and things if you want to grab something on your way out, and hope to see you next month.